All right, so my talk is titled "The Microcirculation Matters: Rethinking Chest Pain Without Obstructive CAD." So our goal is to define what coronary microvascular disease is and its importance, discuss how we evaluate, interpret, and manage patients that have coronary microvascular disease, and then highlight all of our great work at MedStar across the healthcare system and some research we're doing on this topic as well. So of course, with every grand rounds, we're going to start with a case. This is a case from our institution. It was a 59-year-old woman with a history of hypertension, hyperlipidemia, and GERD. She was on good medical therapy, did good preventative testing. She had a calcium score in the past that was 0. However, she saw her outpatient cardiologist and was developing substernal chest pain, mostly with exertion, and then relieved with rest after about 5 to 10 minutes. So pretty typical anginal symptoms. The cardiologist tried to manage it medically first with nitro, along with amlodipine, lisinopril, and atorvastatin. But unfortunately, she continued to have symptoms. So non-invasive testing was pursued with the stress test on the 4th floor here at Georgetown. She had an exercise stress test that showed upsloping ST depressions on EKG. So possibly positive findings on the EKG, but then she had her perfusion imaging, which was normal. And then she had an echo that was normal as well, with no wall motion abnormalities, no valvular issues. So, typical symptoms, but non-invasive imaging was normal for all intents and purposes. However, the symptoms were so convincing that a shared decision was made between the cardiologist and the patient, and the decision was to pursue an invasive strategy. So she had a left heart catheterization here, and you can see it here. The left box here is depicting the left coronary artery, the LAD here, and then the circ in the background. And you can appreciate there's no obvious blockage anywhere in any of the big vessels of the heart. And this is the RCA here. Again, nice, large, dominant RCA with no significant disease. So no big 80%, 90% blockage. However, the interventionalist was also so convinced by the patient's symptoms, and he wanted to ensure that the LAD was free of disease. He spent the time, put a pressure wire down, and did non-hyperemic indices, also known as IFR, or you might have heard of FFR, where we measure flow down the big epicardial vessel, and that was 0.96. Abnormal is less than 0.89. So we just confirmed what we saw visually, that there was no obstructive disease in the coronaries. And then really to labor the point, FFR, which was performed also in the cath lab during this procedure, meaning adenosine was given, and again, epicardial, there was no evidence of any obstructive disease. So my question is, now what? What do you do? Do you tell the patient, hey, it's all in your head, your chest pain isn't real, excuse me? Do you say, hey, maybe your symptoms are coming from your GERD, see our GI counterparts? Do you just put them on all the medications and hope for the best? What do you do? And to be honest with you, 5 to 10 years ago in the cath lab, we would say, your blood vessels look good, try to figure out another cause for your symptoms. But that has completely shifted over the last 5 to 10 years. And I'm excited to show you, what coronary microvascular disease is and how we manage and treat it. So I love this picture. On the left is a picture of a classic angiography. So when we do an angiography, we're looking at the big blood vessels of the heart, the LAD, the circ, and the RCA, and the major branch vessels off of those arteries. These are important. These are the arteries that can cause heart attacks with plaque buildup, and these are the arteries that we treat by putting stents in. But if you look on the right, this is actually what the coronary the circulation looks in the heart. You have the epicardial vessels, and then you have the microvasculature. And you can just appreciate this very complex network of small vessels that help provide blood flow to the muscle that we do not see on our classic angiography. And you can imagine if those are diseased, those can certainly cause symptoms, chest pain, and can even possibly cause, a heart attack presentation. And again, why is this important? When we do our angiography, we see the big vessels. We see the epicardial vessels. These are the conduits. These are the highways that deliver blood down the circulation to perfuse the myocardium to allow the heart to beat. But if you look at it, The epicardial vessels do not really change in tone and exhibit minimal resistance to coronary flow, only about 5%. It's really the prearterioles and the arterioles that make up about 80% of the resistance and tone regulation and distribution to the heart. Meaning, if you are, running a marathon, it's going to be the prearterioles and the arterioles that are going to change to allow more blood flow to the heart, given the increased demand and exercise, to ensure that there's adequate oxygenation going to the muscles so you can run that marathon. And then you can imagine if the blood vessels are diseased for whatever reason, they cannot dilate or constrict to allow proper blood flow to the myocardium, and that can result in ischemia and chest pain. So pathophysiology, when we're talking about microvascular disease of the small vessels, there's two big components that happen. One is you have structural changes to the microvasculature, as you can see here. And the structural changes that you have to the microvasculature are the same structural changes that you have to the epicardial vessel. You can get remodeling, so thickening of the vessel wall due to smoking or long-standing hypertension. And then you get buildup of atherosclerosis, atheroma, just like you can with the big vessels. And of course, all the same risk factors can contribute to this. Again, smoking, hypertension, high cholesterol, diabetes. Now we're checking more and more Lp(a). That can all impact the small blood vessels. So structurally, the microvasculature can change, but then also you can have functional abnormalities as well. If the endothelial cells are disrupted for whatever reason, either inherently or due to buildup of plaque or remodeling, you can get spasm of the small blood vessels, and that can result in development of ischemia, chest pain, and even presentation of an MI. So you can get either structural changes or functional changes resulting in spasm. The spasm is also important because when we evaluate these patients in the cath lab, we do a test, which I'll talk about more, acetylcholine provocative testing, where we can evaluate for spasm in the small blood vessels, and at the same time, look for epicardial vasospasm as well, which we all learn about in medical school and in residency as well, where certain patients have hyperreactive smooth muscles of the large epicardial vessels, and they can have spasm of the big vessels that can cause chest pain and ischemia as well. So pathophysiology, you have multiple risk factors contributing to both structural and functional changes that can result in coronary microvascular disease. The beautiful thing about coronary microvascular disease, as we understand it more and more, we look for it and we treat it, it's almost like the tip of the iceberg. It's kind of like the gateway and can lead to a lot of other diagnoses. There's a big overlap between coronary microvascular dysfunction and Takotsubo. We see that a lot, or stress-induced cardiomyopathy. A lot of patients come in with what we call INOCA or MINOCA, that's myocardial infarction without obstructive coronary disease. And what we find is a lot of these patients might actually be suffering from either microvascular spasm or coronary microvascular dysfunction. And we would never know this unless we evaluate this in the cath lab. And then we also see a beautiful overlap between cardiomyopathies, so both infiltrated cardiomyopathies like sarcoidosis or amyloidosis. Also, we're seeing a big overlap with a lot of the immune checkpoint inhibitors for oncological diseases. So patients being placed on an immune checkpoint inhibitor, they have some sort of cardiomyopathy, or they have like a myocarditis presentation, and a lot of those patients might have concomitant coronary microvascular disease as well, and then also HFpEF in general. Patients with diastolic heart failure, just inherently or due to an infiltrated cardiomyopathy, might be due to coronary microvascular dysfunction as well. So not only are we able to give a diagnosis to a patient and evaluate this in the cath lab, it might also lead to other diagnoses that the patient might be suffering from. So why is this all important? Again, there's low diagnostic yield with just an invasive coronary angiography. When a patient comes to the cath lab, typical symptoms, positive stress tests, everyone thinks they're going to have a prox LED lesion. Only 35% of those patients have obstructive coronary disease that we end up putting a stent in. And we see this every day. Patient comes in, we're convinced, and then their epicardial vessels are normal. 40% are going to have no disease whatsoever. Of those 40%, up to 50% of them have coronary microvascular dysfunction, structural changes of those smaller vessels. If you also do provocative testing with acetylcholine, looking for epicardial spasm and microvascular spasm, it actually is closer to about 70%. So think about all those patients that we've just told, hey, it's not your heart, the big vessels are normal. I guarantee you 2/3 of those patients had some component of microvascular disease, and we were doing a disservice not making that diagnosis for them. And why is this important? Of course, we want patients to, feel well, not have symptoms, not have impact on their quality of life. But more importantly, if you have disease in the microvasculature, you are at an increased risk of having major adverse cardiovascular events in the future. So it's important to identify this, and it's important to get the patient on proper medications. And we'll talk about that in more detail. This is a large study, and what I want to highlight is we do see about 2/3 of the time, it's more commonly seen in women than in men. Men can have microvascular dysfunction, but 2/3 of the time, it's more commonly seen in women. And we're very fortunate here at Georgetown that we have Dr. Srichai in women cardiology, her clinic, to fully evaluate these patients, both non-invasively with cardiac MRI and then invasively with myself and Dr. Hashem. So I just want to highlight that. And there is indications that's typically seen in younger women also. So, women in their 30s and 40s who have been told that their chest pain is not related to their heart, let's reconsider that. It's often overlooked. This is our data from MedStar. It's underdiagnosed, therefore undertreated. Patients will have repeat hospitalizations, repeat non-invasive testing, and even, unfortunately, repeat invasive testing. So they can have, 2 to 3 angiographies, and every time, the big vessels are normal, but then nobody has ever looked at the small vessels before. In our cohort, we saw that on average, it took about 2 years for us for a patient who's suffering from microvascular dysfunction to get diagnosed with the correct diagnosis. And you can see multiple ER visits, multiple days in the hospital, and multiple tests performed on that patient. How can we evaluate coronary microvascular dysfunction? There's 2 ways: non-invasively and invasively. I already mentioned a little bit before. There are non-invasive options. There's echo, but more specific is either PET or cardiac MRI. We're very fortunate at MedStar to have the expertise of Dr. Srichai, Dr. Wiseman, and folks who can evaluate for microvascular dysfunction non-invasively. And it's highly sensitive and highly specific, and we have some ongoing research to really validate that. The only downfall from non-invasive approach is if the patient has never had an angiography before, you don't want to miss epicardial disease if it's there. And then also with the non-invasive approach, you can't perform the acetylcholine provocative testing looking for epicardial vasospasm and microvascular spasm. So that's the only positive of doing invasive evaluation. And we have a shared decision with the patient before bringing them to the cath lab so that they can understand the risk and benefits of the different modalities to evaluate for microvascular disease. So how do we evaluate it in the cath lab? When a patient comes in, they're coming in with angina, okay? Like I said before, it's more commonly seen in women 2/3 of the time. And women, historically, we know that they don't always present with typical symptoms, typical being left-sided chest pain, pressure with exertion that radiates down the arm. Sometimes it might be more reflux, it might be fatigue, it might be shortness of breath, it might be palpitations. So from our standpoint, we take all symptoms seriously. We believe all symptoms is real until proven otherwise. The second step is we do usually like to see some degree of ischemia. That's not always the case. Sometimes their non-invasive evaluation could be completely normal, and we'll still, pursue a microvascular evaluation. But if a patient has a EKG that's abnormal, a stress test that's abnormal, our tenors are even higher, that the patient might have microvascular dysfunction. So we'll bring them in the cath lab. Of course, we'll do our baseline angiography to once again rule out to make sure there's no obstructive disease in the large epicardial vessels. We do that visually by ensuring that there's no stenosis greater than 50%. And then if there's an intermediate lesion, we can put a pressure wire down, do an IFR or FFR wire, measure flow across that lesion and ensure there's no blockage down the vessel. And then if that's all normal for the epicardial vessels, then we proceed with doing our coronary microvascular disease evaluation. So just to talk briefly before I go into the details, the way that we're able to look at coronary microvascular dysfunction in the cath lab is based off of this kind of alphabet soup here of different physiological indices that all kind of measure flow down the heart. It looks complicated, but it's not. And let me just give me a second, I can explain it to you. So what we do is we put a pressure wire down the heart blood vessel, the coronary. And the first thing we're going to measure is coronary flow reserve. So CFR. So what that measures is flow down the coronary tree from the epicardial vessels all the way down to the tiny vessels. And I'll talk about normal, but normal is typically 2.5 or higher. If it's abnormal, then we know that either in the epicardial vessels or in the microvasculature, there's disease or something going on that's wrong, that's leading to the flow to be abnormal down the coronary tree. The way that we're able to figure out where the problem is coming from is on the right. First, we can do our typical physiological indices in the cath lab, which are FFR, RFR, sometimes also known as IFR, where we confirm that there's no significant blockage in the big vessels of the heart, the epicardial. And then we now have technology and software to calculate an index of microvasculatory resistance, also known as IMR. Normal IMR is less than 25. If your IMR is above 25, that indicates that you have resistance, disease in the small vessels of the heart, and that could be contributing to the patient's symptoms. So if we do this and the patient has a low CFR, their epicardial disease is normal, and their IMR is high, that means that they have microvascular dysfunction, but I'll talk about that in more detail in a second. But these are kind of the acronyms and the terms that we use in the cath lab while we're evaluating patients for this disease process. There's two ways that you can do it. One is a Doppler wire. This is not currently approved in the United States. It should be in the next year or so, but just want to let you know there's a Doppler wire. But more commonly, the way that we do it now in the cath lab is we use a pressure temperature sensor tipped wire. This is the wire here. It's made by Abbott. And what it has is a pressure sensor at the tip of the wire. So we put the wire down the vessel, and then we inject cold saline through a 3 cc syringe, and then it measures time, transient time, from the guide to the tip of the wire to determine flow down the artery. This is very similar to how we do a right heart catheterization in the cath lab or in the ICU, like your thermal dilution technique for calculating cardiac output. It's the same as that concept for performing microvascular dysfunction evaluation in the cath lab. So this is Dr. Heider-Hasher's hands here. Again, we just put 3 mLs of cold saline in this syringe. We inject it. It comes out of the guide here, and then the wire measures flow down the vessel. This is what it looks like on the screen. So in order to do the calculations, we have to get transient time, which is depicted here, at rest, and then we give adenosine in the cath lab. We put the patient, we induce a hyperemic state, and a normal hyperemic state is the small blood vessels will dilate and allow increased flow. And then we measure transient time at rest and then at hyperemia, and with the same technique. And then the system will calculate all the important indices for us: FFR, RFR, IFR, CFR, and IMR. And then we can interpret that data objectively, not just like guessing based off the angiography, objectively diagnose if the patient has coronary microvascular dysfunction as well. So this is kind of what it looks like in the cath lab. Those are the logistics. I don't want to bore you with those details, but that's just kind of how we do it in the cath lab. The key thing is, though, is we're not making this up. This is not like we're just looking at the screen and saying it. This is objective data, well validated with new software that's been available over the last 5 years that allows us to objectively make the diagnosis for our patients. Again, the first step is measuring coronary flow reserve, or CFR, and you'll see this in our reports. Normal is 2.5 or higher, and if it's less than 2.5, that means that the flow in the coronary tree is compromised, either in the big vessels or the small vessels. And then we calculate index of microvascular resistance, also known as IMR. If IMR is less than 25, that's normal. If it's above 25, then we know there's resistance in the microvasculature, there's disease, and that's really the gold standard for making the diagnosis of coronary microvascular dysfunction. Now, that is looking at structurally the small vessels and understanding the small vessels to see if they're diseased. What I talked about before is sometimes you can have functional abnormalities in the small vessels, and you can also have epicardial vasospasms as well. So in order to understand that, the second part of the test that we do in the cath lab is we administer acetylcholine through the guide to see if there's any evidence of spasm. Typically, there should not. Typically, the vessel should dilate. But if there's evidence of spasm, and you could have spasm again of the big vessels or the small vessels, that would make the diagnosis of microvascular spasm or epicardial spasm. So this is the treatment algorithm that we do at our cath labs within MedStar. We give gradual escalation of doses, usually in the left coronary artery, because with the right coronary artery, you have a higher risk for transient heart block. So we give 2 micrograms, 20, then 100. And when we slowly infuse that in the coronary over 1 minute. And when we're delivering the medication, we're looking for 3 things. We're looking for development of symptoms. So does a patient develop chest pain on the table? And if so, we ask them, is this chest pain similar to what you're experiencing? 2 is we look for ischemic changes on the telemetry, on the monitoring. If we see like T-waves flip, ST changes, or God forbid, ST elevation, that's concerning, or not concerning. That tells us that there might be something going on with spasming. And then the last thing is we look for evidence of spasm on the angiography. So we give the 2 microgram dose. We look for all that stuff. We'll do an angiography to see if there's spasm, and then we will give 20 and then 100. And that will give us the formal diagnosis of either epicardial disease or microvascular spasm. If the patient develops chest pain and/or EKG changes, but there's no spasm of the big vessels on angiography, that is microvascular spasm. That means that their chest pain or symptoms are coming from the little vessels spasming. If they develop chest pain, ischemic EKG changes, and spasm of the large vessels, and I have an example of it, that's a diagnosis of coronary vasospasm. That's kind of more classic what we learn in like medical school and residency and stuff like that. So this is an example, this is an extreme example of this, but this is an example of epicardial spasm. I'll have to say, and I have a slide, this is an extremely safe procedure. And the way that we reverse acetylcholine is by just giving IC nitro. We give 200 mics of IC nitro, and immediately the effects that we see from the acetylcholine are completely reversed. We do this outpatient, patients go home the same day. So this is a patient that came in with typical episodic chest pain. This is a depiction of her left main and her LAD coming down here, free of disease. Then we give gradual doses of acetylcholine, and then this is her shot at 100 mics. You have complete occlusion of the circ, you have complete occlusion of the left main, and you have complete occlusion of the LAD. This is the extreme example, but it just highlights, you can imagine like the patient is certainly suffering from this spasm. And we have cases, not at MedStar, but we have, we're Dr. Hashem and I are on a lot of like forums and committees, and people present cases, and people present with sudden cardiac death. And we eventually find that they have severe epicardial spasm. I immediately give of nitro, and this is literally 10 seconds later, everything comes back. And of course, the patient developed chest pain, was hypotensive during this middle shot, but we gave the nitro, and the chest pain goes away in 30 seconds. We got this patient on calcium channel blockers along with long-acting nitro, and she's done well ever since. So this is a dramatic example, but this is what we see in real life. The next example is a little different, but also important. Again, a patient coming in with typical symptoms. Her LAD is completely normal. We give doses of acetylcholine 220, 100. She has no epicardial vasospasm, but you can appreciate here that look at this very slow flow down the LAD, right? So this is an example of microvascular disease. So the small vessel spasming, resulting in slow flow down the vessel, but the epicardials are okay, right? They haven't spasmed at all, but the small blood vessels are spasming, and there's dysfunction in the endothelial cells that's causing the patient to have her chest pain. Again, I immediately give nitro, and everything goes back to normal. Same story, give calcium channel blockers, long-acting nitro, and she's done great ever since. But you can imagine if you don't take the time to think about spasm and do the appropriate testing, you're going to miss these patients for sure. Is it safe? Yes. So again, Dr. Hashem and I are not going rogue, just doing this. We discuss this with pharmacy. We have pharmacy on board. We have protocols in place at a hospital center in Southern Maryland. We had to present the safety involved with administering acetylcholine. It's 100% safe. This is a meta-analysis over 12,000 patients, and you can see severe events, as you can see here, was 0.5%. So this is an extremely safe procedure. Again, we do it as an outpatient all the time. Another common thing I hear from my colleagues in the interventional world is, why do I want to spend all this extra time doing all this extra work? I don't have time. I got to turn the lab over. It's all about RVUs. Well, we found that doing coronary microvascular evaluation on average is not that much longer. This is historical data looking at using that pressure wire. And in this cohort, it took an extra 5 minutes to look for the CFR and the IMR to make the diagnosis of CMD. We looked at our experience at MedStar, and we saw that on average, it resulted in only 10 more mLs of contrast used, about 1.5 to 2 minutes more fluoroscopy time, no difference in radiation and dose, and only a 2-minute increase in procedure time. 2 minutes in the cath lab is nothing. And I think this highlights that, it seems like a lot more work in the cath lab, but it's not. And once you are a coronary microvascular dysfunction lab, you get proficient at it as an operator, and then you get the buy-in from the team and the staff in the lab. They get proficient in it, and then it just becomes second nature. And what I love now in my cath labs is when I do an angiography, it's normal, and I don't do CMD testing for whatever reason, and my staff questions me. They're like, "Why aren't you doing it for this case?" I love it. It makes me so happy. All right, so are Dr. Hashem and Dr. Case just crazy? Are they just making this stuff up? They're just going rogue at MedStar? No. So this is all in the guidelines now. This is a newer kind of field within cardiology. More and more evidence is coming out, but it is supported by the guidelines. These are the 2024 ESC guidelines. For the medical students and residents out here, typically, or at least in cardiology, the European guidelines are usually about 3 to 5 years ahead of the American guidelines. They give a class 1 indication for performing CMD testing in the cath lab for any patient who is having chest pain and they don't have obstructive coronary disease. In the United States, this is from 2021. It's still a class 2 recommendation, but these guidelines need to be updated. And everyone in our field, in our world, suspect that once these guidelines are updated, it's going to be a class 1 indication. I'm going to skip this slide, but so what is the importance of doing coronary microvascular dysfunction? So are we just doing it so we can tell a patient, give a diagnosis of chest pain and put them on medication so they feel better? Yes, that's part of it. But the other part of it, again, what I mentioned early on in the talk is if you have evidence of coronary microvascular dysfunction, you're at an increased risk for clinical events going forward. And I have a couple of slides where I could depict that. First, this is just showing if you have low CFR, just low CFR, not if it's due to epicardial disease, if it's due to disease of the small vessels, you're at an increased risk for major cardiovascular events in the next 5 years. If you look at specifically patients with CMD, so those are patients with low CFR and high IMR, they're the most high risk for an increased event in the future. So this is not just a benign diagnosis that we're making where we put them on medications and they feel better. We're also changing their clinical course in the future. And it's not just for patients with obstructive disease. We've also saw that patients who, has come in with chest pain or a heart attack, their LAD, the proximal LAD has a 90% blockage. I put a beautiful stent in, I have beautiful flow down the LAD. I'm feeling good about myself. If that patient walks out of the cath lab and their IMR is elevated, if it's 25 or above, or specifically if it's 40 or above, they're still at risk for major events going forward. So I might have opened up that big artery and I might be feeling great about myself, but that patient is still vulnerable and at increased risk for events in the future. And this is a landmark trial that showed, again, if your IMR is above 40, leaving the cath lab after a STEMI or an NSTEMI, you're at increased risk for events going forward. And we're actually, in our world, there's a lot of new therapies out there, both pharmacological and device, where they're actually trying to target this specific patient population. And they're arguing that, if a patient comes in with a STEMI, you should do IMR testing after the STEMI. And if the acute IMR is above 40, you should potentially possibly do another intervention acutely to help prevent, development of scar, remodeling, heart failure, and worsening events in the future 1 to 5 years after their patient's heart attack. So more to come on this topic, but it's important just to highlight that what we're doing and evaluating has clinical meaningful impact on patients going forward. So this is a state-of-the-art review that came out of JACC a few years ago in 2023 and kind of just highlights a lot about what I just talked about. What I wanted to highlight here is, again, what we just talked about, kind of summarize that a patient comes in with chest pain, you rule out obstructive coronary disease, you look at the flow down the vessel, and you do acetylcholine provocative testing. The important thing, though, is there's a lot of different buckets that patients can fall under. They can have coronary microvascular dysfunction where the small vessels are diseased. They can have purely microvascular spasm where the small vessels spasm, or they can have an overlap of both, or they can have a component of endothelial dysfunction, or God forbid, they might even have like myocardial bridge on top of all that complicates it further, and it's kind of out of the scope of this topic. But what is important to highlight here is you have to do the full microvascular evaluation in the cath lab with both the wire testing and the acetylcholine provocative testing to really understand what we call the endotype. What type of microvascular disease is a patient suffering from? Because that helps impact prognosis. And then what I'll talk about in a minute is also going to impact our treatment strategy for those patients. And one of the key trials out there that really talks about treatment is the core MICA trial. And what they did was they randomized patient to either doing CMD testing or just doing angio evaluation. And what they found is what I just talked about. If you can define the endotype of microvascular disease and target your therapy specifically to that endotype, that results in the patient feeling better and having a better quality of life and preventing major adverse cardiovascular events going forward. So this is all important because, Dr. Srichai and I hear from our colleagues all the time, like, what's the point? At the end of the day, you're just going to put the patient on a beta blocker or calcium channel blocker. Like, why are you wasting all this time? And you'll see that there's small nuances in the different endotypes where one therapy is more beneficial than the other. So if you do not do the full evaluation, you could potentially put the patient on a therapy that's not as effective for them. And then, they're still going to suffer from their chest pain, and all that effort you put, pre-procedure and in the procedure itself will go out the window. So how do we treat CMD? So this is a nice depiction from our European colleagues. First and foremost, this is a component of coronary artery disease. So, lifestyle factors are always going to be important and are always primary for us. Proper exercise, nutrition, weight loss. That's a big one now, and we can have a big impact on our CMD patients with the GLP-1 agonist, smoking cessation, coping with stress as well. We also, I'll talk about, we now have CPT codes related to microvascular dysfunction, and we can even get patients enrolled into cardiac rehab. And that's been very impactful for our patients as well. The second thing is managing risk factors. So the same risk factors that cause coronary artery disease can cause microvascular dysfunction as well. So you want to make sure the blood pressure is well controlled, their diabetes, and their elevated cholesterol. And then we get down to the specifics about microvascular dysfunction. And you can see if they have microvascular angina or coronary microvascular dysfunction, we typically favor beta blockers, with the second line agent being a calcium channel blocker and usually ranolazine. But if they're dealing more with vasospastic angina, either the epicardial vessels or the small vessels, we actually favor calcium channel blockers or long-acting nitrates. So you can see, if you don't know your endotype, if you don't know exactly what you're dealing with, you might put the patient on the wrong therapy, and you might not be treating them as effectively as you could be. This is also from that review, and it just shows, again, the different endotypes that we deal with and all the possible therapies out there to treat them. The unique thing about microvascular disease patients is typically they're dealing with their symptoms for a long time. They've been told for a long time that their symptoms aren't real. So when you finally make that diagnosis for them, they're very grateful, and they become committed to your care. So we see a lot of these patients in the clinic afterwards, and we have found that it does take kind of like a trial and error. Not every therapy is great for every patient. So sometimes we are, using our second, third, even fourth line therapy to treat these patients. And sometimes I'll even share this figure with them and show them, like, hey, these are all the therapies we can try on you. Let's see what works and what doesn't, and we can adjust medications as needed. So that's coronary microvascular disease in a nutshell in 30 minutes. There's more to it, obviously, in the cath lab, but that's kind of the overview. Now, I want to spend about 10 minutes just sharing our experience at MedStar, because in this region, we are the leaders in coronary microvascular disease testing. We're the only cath lab system in the Mid-Atlantic doing testing. We get referrals all the way up from Penn, New York, and all the way down to North Carolina, South Carolina. And patients will come. They will travel to get the answers for their symptoms. So we, with the support of MedStar, myself, along with Dr. Haider Hashem and Dr. Itzik Bendor, rolled out this technology at MedStar Washington Hospital Center, along with MedStar Southern Maryland Hospital. We had a lot of support from MedStar in terms of marketing. We did a lot of community outreach. Community outreach is important because these patients are out there in the community. Not a lot of primary care doctors and not even a lot of cardiologists know about this or think about it. And these patients are suffering, and them knowing that this technology is out them and that we can help them is important. This is from February of last year, I think, where Dr. Srichai and I, along with some other cardiologists, did a live Facebook webinar during Heart Health Month, talking about women's heart health, and I was able to highlight coronary microvascular dysfunction as well. And Dr. Hashem has done a lot of work with our local news correspondents. This is one of the first patients that we ever did, and she told her story on the news, and that really had a profound impact on our program. In addition, we've done a lot of research. I like to think we're one of the leaders in this field, both nationally and globally. Dr. Hashem and I do talks all the time, but then we also have developed the Coronary Microvascular Disease Registry, It was developed by myself and Dr. Hashem under the guidance of senior guidance of Dr. Ron Waxman with MCRN. And this registry has been phenomenal. We currently have 4 sites, 2 in MedStar, 2 external, and we have 5 more pending. We have already done 470 cases in MedStar, and we have about 500 patients in the registry in total. And within the registry, we are, retrospectively gathering all the data about the patient. So how many CAFs they've had, how many stress tests they've had, which medications they've been on before. And then once we've made the diagnosis of coronary microvascular disease, or if they're even negative, we're following up on these patients prospectively 1 month, 1 year, all the way up to 5 years. And we're seeing the impact that our diagnosis and the medications we recommend have on the patients in terms of follow-up. We've written 19 published manuscripts from CMDR. It's not just myself and Dr. Hashem. It's a great work of our interventional cardiology fellows, along with our general fellows, and a lot of medicine residents as well. And certainly if any medical residents in the audience, if they want to get involved, you're more than welcome to. We have a lot of research ideas, and we'd be happy to help support you. And just roughly in our experience, when we do microvascular testing, on average, we are diagnosing coronary microvascular disease about 60% of the time. So 2/3 of the patients that come in have coronary microvascular disease. And of that, 2/3 are coronary microvascular dysfunction, and about 1/3 to almost half have some component of spasm as well. So we're making this diagnosis almost every day. It's extremely gratifying because the patients usually are suffering for so long, and they are very grateful from our making our diagnosis and putting them on the right medications that are necessary for them. This is just some highlights of some of the publications we've done. We've looked at non-invasive testing like a CT. So every patient that has coronary microvascular dysfunction, they've had a CT at some point, ruling out a PE, ruling out coronary disease, ruling out lung pathology. So we took all of those coronary CTs and we looked at epicardial fat. And we saw that the more epicardial fat you have on a CT, the higher the risk of having coronary microvascular disease. So this small indication is just another marker that we can look at for our non-invasive testing. And, if somebody has a high epicardial fat content, we can say, hey, there's a high risk that they might have coronary microvascular disease. We've also saw that there's a higher incidence of arrhythmias, specifically ventricular arrhythmias like PVCs, NSVT, and even VT. So if you have a patient that has, chest pain, they've had NSVT on a Holter monitor, they've had a stress test that was negative, or they've had an angiography in the past that was negative, some of those patients might have coronary microvascular disease, and it's worth getting an evaluation. And we've even written a review about the overlap between, like I talked about before, oncology treatments and its impact on the microvasculature. And we've published a lot of papers with our cardio-oncology group and our cardio-oncology department here at Georgetown. And this is a whole subspecialty within microvascular disease that needs to be fully explored. And there's a ton of research opportunities. This is really just the tip of the iceberg. So a lot of research opportunities in that world also. And then what's very exciting is that we now have CPT diagnosis. Dr. Hashem actually led this along with some other experts across the country, where we now have CPT codes. This is important because one of the things we heard from our colleagues in the interventional world was, they couldn't bill for it, right? They couldn't bill for coronary microvascular disease, but now they can with this diagnosis. And this diagnosis also helps with, again, getting patients into cardiac rehab, or if we want to do a follow-up PET scan, getting approval for that. And then also having CPT codes will allow us to do further retrospective research projects using large Medicare registries now that we have these CPT diagnoses within those Medicare registries. One other thing I wanted to talk about that we're doing at MedStar is, we talked about there's pharmacological options for treating coronary microvascular disease, like calcium channel blockers, beta blockers, long-acting nitrates. But there's also non-pharmacological devices that we're now exploring to also treat patients with angina due to the microvasculature. Specifically, what we're looking at is the coronary sinus reducer. And you can see it's right here. It's a small mesh-like metallic hourglass-shaped device. This device was initially developed for patients with obstructive epicardial coronary disease without a revascularization strategy that was still having chest pain despite being on optimal medical therapy. Now we're looking at this device, seeing if we can use it for patients with coronary microvascular dysfunction. And what it does is it's a device that we place in the coronary sinus. So this is a depiction of the procedure itself. This is a wire or catheter that's coming from the right IJ, so it's a venous stick. And then there's this wire is wiring the coronary sinus. We're wiring the coronary sinus the same way that our EP colleagues wire the coronary sinus when they're putting in like a BiV AICD. We then deploy this coronary sinus and the reducer. And what it does is it impedes the flow of the coronary sinus, meaning the blood flow takes a longer time to get into the coronary sinus, and then ultimately go into the right atrium. And that back pressure results in more blood flow, more oxygenated blood flow going backwards into the microvasculature and staying into the myocardium of the muscle to allow more time for the muscle to oxygenate and take the blood, take the oxygen off of off the red blood cells to relieve the symptoms that the patient is experiencing. So this is being evaluated at Washington Hospital Center. We're doing this procedure specifically to see if it can help patients with coronary microvascular dysfunction. This is great because it's just another tool in our toolbox to help these patients. So back to our original case. If you remember, this was a 58-year-old woman, typical symptoms. Non-invasive testing was pretty much uneventful, and her angiography demonstrated normal epicardial vessels, again, that we see here. So 10 years ago, we would say, your epicardial vessels are normal. This is probably from your GERD. Go see a GI doctor. It's not your heart. But of course, now we decided that we wanted to do coronary microvascular dysfunction evaluation on her. So we put the wire down. We first looked at the epicardial disease vessels, make sure they were not diseased. Her RFR or IFR was normal. We then did the FFR, again, normal. But we're not happy yet. We want to look at the small vessels. So we started with our acetylcholine provocative testing. We started with 2 mics. With that, no EKG changes, no chest pain, and no change in the caliber of the flow of the vessel. So far, negative acetylcholine provocative testing. We go to 20. Once again, no EKG changes, no symptoms, and all intents and purposes, no significant spasm of the LAD. We go to 100. Again, no EKG changes, no symptoms, no spasm of the epicardial vessels. So we're happy so far. Patient has no epicardial vasospasm and no microvascular spasm. But like I said before, that's only half of the test, and we want to make sure we're not missing another endotype. So we decided to put that pressure wire down and perform that bolus thermal dilution technique where we measure flow down the artery at rest and then hyperemia. And then the software does the calculation where we can calculate CFR and IMR. So we did that, and you can see here that her CFR was 2.2. Again, normal is 2.5 or above. So her CFR was normal, so the flow was compromised. And the IMR, the index of microvascular resistance, was elevated above 25 at 34. So this patient was suffering specifically from structural abnormalities in her microvasculature, and that's formally the diagnosis of coronary microvascular dysfunction. And if you go through our algorithm, so she came in with chest pain. We did an angiography. The epicardial vessels were normal. So then we moved on to did our coronary functional testing. We did acetylcholine provocative testing, which was negative. We then looked at the flow to diagnose to see if there's abnormalities in the IMR, index of microvascular resistance, and that was positive. So she was formally diagnosed with coronary microvascular dysfunction. She was placed on beta blockers along with ranolazine, and we have been following with her ever since, and she's been chest pain free ever since making this diagnosis. So thank you for this kind of whirlwind of what we're doing. Of course, there's a lot more technical aspect to it, but I just wanted to give everyone an overview of these patients. Realize that this disease process is out there. It's out there a lot. It's real. We can do a formal evaluation here within MedStar, and we can have a dramatic impact on these patients, not only their symptoms and their quality of life, but we can impact their trajectory long-term in terms of avoiding adverse clinical events.